Hi, welcome to the Doctor Who Show. I'm your host, Nick Cicero. Our guest today is Dr. Kevin McElroy. Dr. McElroy is board certified in pain medicine and physical medicine and rehabilitation. Dr. McElroy was instrumental in developing the Interventional Pain Medicine Fellowship at JFK Medical Center, which provides comprehensive pain medicine training to high-level selected candidates. He's been practicing in Bergen County community for many years. Please welcome Dr. Kevin McElroy. All right, Dr. McElroy, thank you for joining us.
Thanks for having me.
So where did you grow up?
In Bergen County, small town, Glen Rock. I moved there when I was 5, Glen Rock High School.
Were your parents born and raised there?
No, they were out in the Bronx.
Oh, the Bronx.
Yeah, they met out there, got married and moved out here when they were 18.
Okay.
Started a family, had my brother and I.
At 18?
No, we waited a couple years. wasn't that quick.
Were their parents born in the Bronx as well, or did they come over?
My father's parents were born in Ireland, and they came here. My mother's parents were born in the city. Their parents came over from Ireland.
Oh, okay.
So, go back to the old country.
Did you stay, did they stay in Brooklyn for a long time?
In the Bronx.
The Bronx?
My parents?
Yeah.
My grandparents stayed for a while, but then my father was the second oldest of 9, so as each one of them started to move out of the Bronx, they moved out to Jersey too.
9?
Yeah, it's a stereotypical Irish Catholic family.
Holy!
Yeah. 3-bedroom house, a boy's room, a girl's room, and
their
parents.
room.
Yeah.
So your family reunions must be
a little chaotic. Yeah. We don't really go to them because they're a little crazy. But yeah.
It's like, hey, do you want to rent out Giant Stadium?
right. Yeah.
That's
Pretty
a lot.
much,
Is your wife's side have a lot of
no.
siblings? Your wife's parents?
So she has 3 aunts and uncles, like 3 uncles, and then their wives, so they're a little bit smaller.
Okay.
I have 13 aunts and
That's
uncles.
overwhelming.
Yep.
Wow.
Yeah.
Did you get a lot of cards in the mail with cash?
They never have cash.
They never have
Yeah,
cash?
a lot of cards, no cash.
My aunt used to call me and say on my birthday, I played the lottery, I didn't win. I didn't win. Not
You call
today.
around when you want to see the tickets?
It's like, man, I never got a card saying I won. Here's $10.
After all those years.
Yeah. Did you always know you wanted to be a doctor?
For the most part, I think I vacillated back and forth from doctor and veterinarian, but it was always something health related, taking care of somebody.
Did you have a lot of animals and pets growing up?
As a dog, I don't know why I chose, I was pretty young, 5 or 6 when I, decided that medicine was really influenced by my mom. She's a nurse, and my father's a contractor, so they really wanted me to focus on education, and with my mom's experience, I've just kind of gravitated towards people medicine rather than animals.
Did she help you in navigating what part of healthcare you wanted to go into?
Yeah, she helped me as far as getting into medical school, and now everything that went along with that, applying, making connections, meeting people, and that sort of thing.
Yeah.
But after that, you're kind of on your own and just figuring out where you're going to go from there.
Yeah, well, that jumping off point's invaluable.
Yeah, absolutely.
I didn't have anybody in the healthcare industry.
Right.
So I find it, it'll be an advantage for my kids if they want to go that route.
Yeah, absolutely.
Because I know so many doctors and nurses and hospitals.
Sure.
That helps.
Before I applied, I must have spoken to 5 or 6 doctors that she knew just about what medicine's like and what my life would be like, 10 years in the future.
That's huge.
Yeah, you need to know that kind of stuff because, you get an impression as a patient or as a non-medical person of what a doctor's life is. When you get the other side of the story, it's not always the same. So it's good to get that sort of like
Did they let you shadow them at all?
Yeah. Did a lot of
that. During the summer. Or
right. Yeah.
That you learn quick what you didn't want to do.
Yeah. No, that was an easy lesson to learn.
Starts putting on the gloves like,
not
that one.
Right.
Let's go
Check
to
that off
something
the
else.
list. Yeah, right.
Yeah. So what college did you end up going to?
Rutgers.
Okay.
So I'm in Jersey.
Did you apply? Did you want to stay in Jersey? Was that your plan?
Yeah, I actually ended up at the University of Richmond as a freshman.
Oh, okay.
I had a scholarship to go there. Unbeknownst to me, that was a 1-year scholarship. So once year 2 rolled around, I couldn't afford tuition anymore. So I actually transferred back to Rutgers and then finished my last 3 years there.
And how was that experience for you?
That was great. It's Rutgers has a great reputation now. It didn't, when I was there. It was sort of transitioning. But the education was great, second to none.
That was medical school or undergrad?
Undergrad.
Undergrad.
Yeah, and medical school is also through the state system. It was UMD&J at the time, University of Medicine and
Is that
Dentistry.
Newark?
There's 3 campuses: Newark, New Brunswick, and down in Stratford, which is where I went, down in South Jersey.
So what makes you go to which one?
So the osteopathic school where I went is down in Stratford. So that's where I went. The other 2 schools, you apply to the 2 of them and you kind of make a decision, assuming you get into both, where you prefer to go.
Did you have an idea of what type of medicine you wanted to practice at that point?
Yeah, I played sports, recreationally, nothing competitive, but growing up, high school, a little bit of club stuff here and there. So I wanted to do something with athletics, which is why I went into osteopathic medicine, because it's focused more on musculoskeletal system and sort of that angle of things. So initially my thought was orthopedics, just because I didn't really have much research into the available options to treat the musculoskeletal system. So that was my initial plan, was to go into orthopedics. That sort of got adjusted as I saw sort of surgical treatment options versus conservative things. I was more drawn towards preventing surgery if at all possible. So,
well, that brings me to a really good question. For the people out there that are watching this, can you tell them the difference between a DO
Sure.
and an MD or an internal med or
Right.
practice?
So, if you kind of went online and Googled the difference, the answer would be that a doctor of osteopathy or a DO looks at a person more as an individual with a medical condition or a certain problem, whereas an MD or a traditional physician may just look at it more as that condition. So in my specialty, we do a lot with herniated discs. So, and this is changing, but the traditional answer would be a DO would look at not just, your L4-5 herniated disc, but Mr. Jones, who can't pick up his granddaughter because of his L4-5 herniated disc. Whereas traditionally, you would focus more on just the disc pathology and how to treat it. And I think as time has gone on, the 2 specialties have sort of merged their way of thinking. So now most physicians sort of approach it the same way, and we try to be centered more on the patient and their outcomes and their impacts on what their disease process is, rather than just what the disease is.
Understood.
The traditional answer, and if you Google it, that would be the answer. And the focus more on the musculoskeletal system, and that continues. We have a little additional training in some manual techniques as an osteopathic doctor that MDs don't typically do.
So, 15 years ago, the care path for a regular MD, internal med, GP would be one set of rules for that issue, right?
Yeah.
For that diagnosis. And with a DO, you're looking more at the whole picture, and correct me if I'm wrong, are you including homeopathic stuff, PT, physical therapy?
It's some physicians, some of the older physicians might look at things, separating them in that sort of mind frame. But really, I think today everyone's approaching it more from a holistic standpoint. There are some osteopathic physicians who will do more homeopathic treatments. It's separate than what most traditionally trained osteopaths will do. The training now, medical school is still separate, but internships, residencies, fellowships, they're all integrated.
Yeah.
And that's really where you learn how to practice medicine, is in your postgraduate training. So that approach to the patient.
The no sleep.
Yeah, the no sleep 5 years. That's when you learn how to do it. So that training is very similar across both training, both degrees.
Yeah. Well, I think it's important to bring it up to the people because I just had my dad's 80th birthday party this weekend, and I was listening to 2 different generations of people.
Yeah.
My dad's friends who are all in their 80s, and my friends who are in their 30s and 40s.
Right.
And both of them were like, no, DOs aren't regular doctors.
Yeah, right.
They deal in vitamins and this and that. And I had to walk over to 2 different people like, no.
Right.
They're all doctors.
Yes.
And that's important to know.
4 years of med school,
Yeah.
internship, residency, fellowship. There are some, and just like there are some MDs, there are some DOs who will do alternative medicine and focus on homeopathic, natural treatments. But it's not exclusive to DOs, or it's not predominant of DOs. I mean, most DOs will treat patients similarly as MDs will today.
Okay. I think it's important to highlight what you said before, that that all doctors now are following kind of your care pathway of how you were taught and what the DO care path is. They're
Yeah.
all kind of integrated.
Yeah, it's a focus on patient-centered sort of treatment, and looking at what the patient can or cannot do as a result of their condition. And that's what's ultimately most important to the patient. They don't really care if it's a herniated disc that's stopping them from doing what they want to do. They want to be able to do what they want to do.
Right.
And that should be everyone's goal. It should be the patient's goal. It should be the physician's goal, is treating the patient the way they want to be treated with the goals in mind that they have, not necessarily what we have as physicians, but what the patients have.
That's good, yeah.
And I think most physicians are trending in that direction.
Well, on that note, tell me about your practice.
So our practice is a combination of pain medicine and physiatry, or physical medicine and rehabilitation. I have one partner, and we have a physical therapist there. And my partner and I started the practice after similar experiences first out of residency and fellowship. We were working for someone else, and it was mostly a pain practice, meaning we would see patients. They may or may not have had physical therapy at that point, and we would advise them on injections that might be appropriate. But that would be the only treatment option we would really have for them at the time that we would meet with them. And we refer them to PT. They might have had PT, but we never knew the exact treatment they got. And we always had the feedback that PT didn't work for me, or maybe it did work, but it only lasted a few weeks, and now I'm back in pain again. And really, if you do physical therapy correctly and you follow through with everything, it should be the definitive treatment for most issues, and that should really be what you're thinking about doing, and not necessarily relying on drugs and medications and injections even. So we started a practice where we could oversee our physical therapist and see our patients doing rehab, making sure they were getting the correct rehab. So they weren't spending 45 minutes with an ice pack on, and then a stim, and then a heat, and then ultrasound, and then going home, because that will make you feel better for a half an hour, but it's not going to lead to any long-term change. So our physical therapy is active rehab, strengthening, flexibility training, to try to correct any imbalances or any problems that are leading to more significant pathology. So
movement.
Yeah, absolutely. And functional sort of things. So that's why we started the practice, so we can sort of adjust our physical therapist and hire the right physical therapist who's going to think the same way. And we also limit our patient visits with a therapist. He only sees 2 patients max at a time. So traditional physical therapy places will have 4, 5, 6 patients there at a time, with one therapist, an aide, maybe a student, and you get very little interaction with the actual physical therapist. And that's a lot of people's reservation about going to physical therapy, is I could do this at home. No one's really helping me. No one's really doing anything. But a good physical therapy program will have the therapist with his or her hands on, treating you, guiding you in your exercise program, and that's what we do at our practice. We keep it, one-on-one, max 2-on-1, so you really get good time with your therapist, and you really see changes and long-term improvement.
All right, this segment gives patients some educational tips on managing their daily life as it pertains to your field of medicine. You ready to go?
I'm ready.
Okay. So let's talk about sedentary jobs like office workers. How should a person that works behind a desk set up their workspace to make it less taxing on their body?
It's a good question, because obviously a lot of people have sedentary jobs. So the thing to think about is 90 degrees. You want your body to be at 90-degree angles as much as possible. So starting at your feet, you want your feet flat on the floor. And you raise the height of your chair to get your knees to bend at 90 degrees. So most people are higher than that, and so they're kind of having to lean forward a little bit to reach the rest of their equipment.
Right.
Then their arms should be at 90 degrees as well. Keyboard should be at hand height, so you're not lifting up or not lowering your hands. Same with the mouse. Everything that you're doing should be at this level. Not to put pressure on your wrist or your elbows as well, so you want to rest on your forearms. Then the most important thing for your neck and upper back is to have the screen height at the right height. So what you want to do is that eye level should be the top of the screen. A lot of people will have the middle of their screen at eye level if they're trying to set up something ergonomically, but it really should be the top of the screen.
So the top of the screen should be at
eye level. Yeah, that'll keep your neck from having to bend forward while you're doing your work.
Okay.
So, and ideally you could have a standing desk, or at least an adjustable desk, and then everything in the legs sort of goes away and you're just sort of standing straight, but all the upper body stuff remains the same. So keyboard at the level that you can keep your elbows bent to 90 degrees, and then eye level is the same. Top of the screen at your eyes.
Okay. Is there a certain amount of time where you should start standing up?
In an ideal situation, every hour you should take a good 5-10 minute break. That's not always acceptable at a workplace.
Sure.
But an adjustable desk sort of eliminates that. If you can stand, you can continue to work, and you're boss really shouldn't have too much of an issue with that.
Yeah.
But taking a 5-10 minute break to walk around the office would be good for your back, but may not be good for your boss. So
Okay. Well, if you can get your boss to let you get up every hour just for a 10-minute,
yeah,
are there any stretches that you recommend that they could do throughout the day?
It's being in that position, you get tight in the front and sort of weak in the back. So the two main areas that you want to focus on when you're stretching is your chest and the front of your shoulders, and then your hip flexors. So a good chest-shoulder stretch is to reach behind you, clasp your hands together, and then try to straighten your arms. You'll feel some pulling in your chest and shoulders when you do that. As you get used to that, if you're able to fully extend your arms, you can start to pull your hands away from your back to get a better stretch. And that sort of loosens up your pecs and your shoulders and prevents you from sort of becoming rounded like this, which causes a lot of shoulder and neck issues. The hip flexor, you kind of have to do that standing for the most part. What you can do from a standing position is take a step backwards and then slowly start to lower that leg down to the floor and down onto your knee. And what's important is you'll start to feel a little bit of a stretch in the front of your hip there, but you want to make sure your body is straight, again at 90 degrees perpendicular to the floor. Then you'll feel a good stretch in your hip flexor here. If you can't get down onto one knee, if you have knee problems or anything else, you can do that standing, hold onto a chair, grab your foot and sort of bring it behind you. Typical quad stretch, but then you can kind of pull a little bit more and focus on your hip flexor. To focus on the weakening sort of back and glute muscles, there are a lot of good core strengthening exercises, but if you only have 30 seconds, a minute a day to sort of get some of this stuff in, the one exercise I would recommend is doing a plank. So if you're not familiar with that, it's basically down on the ground like you're doing a push-up with your arms under your shoulders, and you sort of just hold yourself in that position. But it's important to make sure that you're straight. Your back's not curving, your neck's not curving.
Your butt's not up.
Yes, right. And you want to contract your abs and your glutes to sort of to maintain that posture. That might be challenging at first, so you can actually go down to your elbows. That makes it a little bit less taxing. Or even if you can't accomplish that, down onto your knees. And the goal is to hold it as long as possible, 30 seconds, 60 seconds, realistically. As you get better, you can start either getting up onto your forearms or onto your hands or holding it longer.
Okay, that's good. For the weekend warriors such as myself, who get nicked up over the weekend from doing team sports like hockey or Spartan races, please put this controversy to bed for me once and for all. When do I use ice and when do I use heat?
Another good question, one I get a lot. There's confusion among primary care doctors and internists about that as well. You want to think about ice after activity or heat after you've kind of been sedentary. So if something happens or if you do something, you're out playing, you sprain your ankle or you get bruised, you want to use ice. And the purpose of using ice is to reduce swelling and reduce blood flow. So after an injury or after an aggravation, your body's tendency is to increase blood flow and increase swelling. That's counterproductive to you sort of progressing with whatever you're doing. So ice helps to reduce blood flow and reduce swelling. If you applied heat in that situation, you're going to do the opposite. You're going to increase blood flow and make your swelling worse. So the role for heat is someone with a chronic back injury or neck injury who wakes up stiff in the morning or is sitting at their desk all day and gets up and they feel tight and stiff. You put a heating pad on and that will help increase blood flow and start to relax some of your muscles. It's important that either with ice or heat, you don't apply ice directly to your skin and that the heat's not obviously too hot. You can cause damage to your skin in either situation. And you want to make sure that if you have any sensory issues, like from diabetic neuropathy, to not apply either of those to anywhere you can't feel, because although they're safe and very effective, they can cause some injuries to you as well.
And so no heat for joints then?
Generally, it's not, if you're applying it directly to a joint, there's not a tremendous role for heat. If the muscles around your joint are stiff, then it's helpful. But someone who's arthritic or who has a ligament sprain or a meniscus tear, generally ice is preferred to heat in that situation.
Yeah, when I was in high school playing sports, we had our trainer he was one trainer for everything, soul guy,
right.
Put ice on everything.
Yeah.
No matter what it was, ice in it,
Right.
ice in it. Didn't matter what it was.
Right. Good first step.
Yeah. Yeah. On that same topic, when ice and heat don't solve the problem, what is the next steps? Like pain medicines, injections? Where do you start?
Sure. So pain medications, if you're paying attention to the news at all, they're getting a lot of bad press, and for good reason. It's not the direction you want to go, if at all possible. What happens with pain medication is that it works for a little while, and then it stops working. So if you're not treating your pain any other way, you're sort of going to become dependent on those pain medications as your need for a higher dose continues. So especially with narcotic pain medications, there's definitely a role for anti-inflammatories, muscle relaxants, and those things after an acute injury. But really the focus should be on rehabbing and improving what's actually wrong with your body rather than using medications to either mask the pain or help reduce the inflammation. So the first step after an injury should always be an evaluation, but in nine times out of 10, it's going to be physical therapy, rehab, trying to address whatever injury you suffered. Injections are useful to sort of facilitate that rehab plan.
Right. I think you bring up a really good point that all the viewers out there should know. There was a stigma around pain management doctors, 10 years ago, of just being guys writing scripts for drugs.
Right.
And it's important, if you just listen to what he just said, you see that that's not the direction of, I'd say, the majority of your profession now.
Yeah, my peers, the men and women that I train with, our focus is keeping people off of narcotics or helping them get off narcotics. It's sometimes a challenge for people that have been on it for a while, but it is really one of the things that we're trying to accomplish every day. Not just myself, but most pain management doctors.
Yeah. I want to talk about stem cells for a second. I see how they're just becoming the workhorse of many new and cutting-edge regenerative medicines projects all over the place. You're constantly hearing about it. Where do you see the future of pain management as it pertains to stem cells?
So it's one of the main tools in our chest to try to help patients who are struggling with narcotics or potentially could be going down that road. If you follow that typical care path that we were talking about before with physical therapy as your first option, some patients don't respond and their injuries linger. So traditionally you're left with surgery or medications at that point, assuming you can't get better with physical therapy and injections. So many people are afraid, and rightfully so, of surgery, that the outcome's not always guaranteed. So they would rely on medications, whether they be narcotics or anti-inflammatories, but medications with side effects. So stem cells offer the potential to actually heal your injury without surgery. So these cells can grow into any tissue in the body. That's what makes them so interesting. So if it's a meniscus tear or a rotator cuff injury, simply with an injection you could potentially regrow the tissue that's been damaged. And that's why they're so exciting for even more serious diagnoses like cancer and diabetes, spinal cord injuries, because they have that potential once we're really able to bring it out in them.
So those first places that you mentioned were places that don't get blood flow, correct?
And stem cells don't typically flow to those areas anyway, but those areas with poor blood supply lead to chronic injuries, like rotator cuff injuries and tennis elbow, golfer's elbow. Those are poor blood supply areas. So your body has a difficult time healing injuries to those body parts.
And when you do that, do you do it in the office? Do you do it in a surgery center? How do you perform it? What's the steps for it?
They can be done in either location. I generally prefer to use a surgical center just because the equipment is there, the room is sterile, it's clean, you have more support staff. So it's a 15 to 20 minute procedure. The stem cells are taken from your body, either from your fat cells or from bone marrow.
People will be happy to hear that.
Yeah, that's right. A small amount of fat. I get that request a lot. But
take a little more out of that part right there.
No, it wouldn't come out. I'd be a little lopsided if I was trying to do that for you. And it's processed the same day, and then injected into wherever it needs to be. So it's a one-day procedure. There's no restrictions afterwards, typically. The most would be a week or so of partial weight bearing if you're doing it into an ankle or a tendon in the foot. But generally, you're back to doing your normal activities the next day, and then within 6 weeks to 3 months, you start to notice improvement.
And you can monitor this through imaging?
Yeah, so obviously the patient's response symptomatically is the most important. If they're feeling better, that's our goal. But 3 to 6 months later, if necessary, an MRI or CT, whatever we're evaluating, could be done to see what has changed prior to the injection.
So it can literally repair that torn labrum or...
Sure. Yeah, we see it all the time. Patients, the most common reason we do these is for knee issues and shoulder rotator cuff injuries. And we'll get follow-up imaging 6 months to a year later, and what was there before, whatever tear or injury was there, is gone.
So it doesn't matter how much it's torn, if you give it enough stem cells and time and therapy?
It does actually matter. A fully torn tendon will not respond to stem cells in all likelihood. Usually by the time something's fully torn, it's retracted, meaning that they're sort of separated. So there's the stimulus to regrow is not there. So in a fully torn tendon, that's usually surgical treatments. But no, stem cells in that situation probably would not be effective.
Okay. Other than stem cells, what new and exciting innovations regarding patient treatment is here or is coming down the pike, especially to your practice?
So something we started doing recently that's really exciting to our patients is treating symptoms in the legs, cramping, pain, burning, tingling. A lot of times it's attributed to the back and a spine issue, but many times we found that it's more of a blood flow situation, a vascular problem. And 3 or 4 years ago, the treatments for that were either these horribly compressive, uncomfortable stockings that you had to wear all the time, or really barbaric surgeries like vein stripping, where you would strip
Literally
veins out of their legs. Yeah. So now what we do is simply with an ultrasound, we're able to diagnose where the problem is. And then using a small catheter that gets inserted through the skin just with a needle, so there's no incisions, no surgery, no sutures afterwards. That catheter goes into the vein that's affected, gets heated up with radio frequency probe, and that closes the vein. And what that does is it reroutes the blood supply back to the good functioning veins. So within a few days of that procedure, you have symptomatic relief. It helps cosmetically with varicose veins and spider veins, and patients are thrilled. Before they were presented with really options that were not acceptable to them. Now they have a simple same-day treatment option for them.
What's this called?
So it's varicose vein radio frequency ablation.
Okay.
And
ablation stands for that?
Ablation is that heating up part of
part.
the process. Yeah, it's covered by insurance. Because of the symptomatic improvement that comes along with it. There's no need for medications, all those compressive dressings, and it's really a definitive treatment for it.
And what's the downtime of the patient?
It's the 1 day of the
Recovery
procedure.
time.
Yeah, they have. They'll be in. It's done in the office. With no anesthesia. It's a local anesthesia. The next day they're back to work.
So they could walk on it?
Yeah. You walk in, you walk out.
Oh, okay.
Yeah, drive yourself home.
Oh.
Yeah.
Oh, that's pretty easy.
Yeah. Simple.
And the success rate on it?
It's very good, 90%.
So radiculopathy, pain, better known as pain down the legs, it's something most Americans deal with on a daily basis. At Progressive Sport and Spine, what are the 3 first steps you take to correctly diagnose the patient?
So like most diagnoses, the majority of them can be made just with a good history and physical. So that means asking the right questions about where the pain is, how did it start, where is it going, how does it feel, is there burning, and then actually listening to the answers. That's an important part of this too. You're able to get a good idea of where things are coming from and where the pain's emanating from. Most physicians, and what we would probably do in that situation, is order an MRI to sort of confirm what our thoughts are as far as where the pain is coming from. And we'll see some pathology in the spine, but the problem is a lot of people have issues in their back on MRI without symptoms. So depending on the studies you read, people over the age of 40, anywhere from 50 to 80% of them have a disc problem on an MRI, and that's without having back pain. So you can falsely attribute symptoms in the leg to the back in a lot of cases because you're looking at MRI findings that aren't really causing the pain. There are instances where the patient's pain is in a specific location and it correlates perfectly with an MRI finding, and you're pretty confident in what your diagnosis is. But if there's ever any question, what we would do is what's called an EMG, or nerve conduction study. We're looking at his nerve functioning at that point, and that gives us a static image in the MRI, a good history and physical, and a functional test of the nerves to see exactly where the pain is coming from.
Do you use the EMG and the NCV, that's what it's called? Do you use that on other parts, or is it always just for pain?
No, it's a test that's used for any really neurologic condition outside of the brain and spinal cord. It's what we call the peripheral nervous system. So in the pain management world, we use it mostly for radiculopathy, pinched nerves, neuropathy from diabetes, carpal tunnel syndrome, some peripheral nerve injuries around the elbow and in the neck. But it's also useful in diagnosing a multitude of neurologic conditions, from autoimmune conditions like myasthenia gravis, and then some other more rare conditions that we use with more serious implications for the patient. But it's a test that can really look at the entire neuromuscular system outside of the brain and spinal cord.
Does it hurt?
It's not the most comfortable test.
What can they expect?
Yeah, most patients will look online and be terrified of the experience they're about to have when they have a nerve conduction study. But generally, it's a lot less painful than patients think. So there's two parts of the test. The first is the nerve conduction part. We put some electrodes, which are basically stickers, on the patient's leg or arm, wherever we're examining, and we discharge their nerves with a stimulator. That's a very brief burst of electrical current, similar to a static shock. Like in the wintertime, you touch a doorknob and get a little static shock.
It does.
Yeah, so they're not the most comfortable thing, but you do that a few times. We get to record how fast and how large the nerve's responses are to that stimulation.
Yeah.
That's generally the least tolerable part of the test. The second part of the test is an EMG or electromyography. We use an acupuncture-sized needle, and we put it into a select group of muscles to sort of examine how the muscles are functioning. Most patients tolerate that without much of an issue because the needles are very, very small. So it's really that first few shocks that we have to do, but generally patients tolerate it much better than they're anticipating after reading some information about it online.
Right. So when that needle goes in, what are you looking at a screen? What makes you understand what's going on?
Sure. So with the needle part of the test, you're looking at a screen and listening. So there
What
are.
are you listening for?
So you're listening to the electrical activity in the muscle. So there are characteristic sounds that abnormalities will make. You can see them on the screen. They have specific waveforms that you'll notice, and then you'll also hear very characteristic sounds as well. And different types of abnormalities lead to different diagnoses. So you're doing both listening and watching the screen as you're doing the test. With the nerve conduction study, there's nothing audible there. That's all just on the screen. You're looking at how fast the nerve is responding.
So when you do your history and then your manipulation to kind of move the patient's body around and see what's going on,
Sure.
and then you do your MRI, if you don't have a definitive answer, then you'll go to the NCV or EMG, or you do all three with everyone?
No, it's not a routine approach. It's really individualized. So if we have the diagnosis after a history and physical, we may not even need an MRI depending on the treatment that we're going to undertake. But generally, we'll want to know what's going on with an MRI. If at that point we're confident in what we're dealing with, then there's really no need for the EMG. That's there as confirmation, or if we're going to proceed with an injection of some kind, it does help us to localize the level of the lesion, meaning we're able to tell not only is it your low back, but is it your L1, your L2, your L3, or so on, so we're able to do the injection at the appropriate level.
Can you clear up when a patient should get injections, how many injections they should get?
Sure.
And what is the medicine that you use in those injections? Because there are so many people with misinformation out
Sure.
there about the care and about the care path, actually, for the injections.
Absolutely. So generally what you'll hear if you ask or you look online, how many epidural injections can I get, you'll get the answer of 3. And that's 3 in a 12-month time period. The problem becomes deciding that you're going to do 3 injections before you start doing the injection. So it's not everyone who's getting an epidural needs 3 epidurals. You would do 1 and then reevaluate at that point. If the pain is improved enough, there's no need to do a second or third unless you have a partial response and you need to get a better response. Really, if you're getting an epidural or have had an epidural, the purpose is really to facilitate something else, usually rehab. So when your pain is at a level where you're able to do physical therapy and rehab, you don't need to have any more epidural injections. You want to minimize the amount you're getting and maximize the amount of rehab and physical therapy you're doing.
What medicine is actually in the injection?
So typically there are 2 medications that will be injected together. A longer acting anesthetic. Most pain doctors that I have worked with who use Marcaine. It's a long acting Novocaine like you would get at the dentist office. And then a form of cortisone. Depomedrol, Kenalog, different kinds. It's really the cortisone that helps to reduce the swelling and the inflammation.
Cortisone is a
really strong anti-inflammatory, a steroid. That really helps to reduce the inflammation around the nerve, and that's the purpose of the injection. Relieve the inflammation, relieve the pain, and then allow you to rehab.
Understood. And there's no downsides to the injection. Is there any?
So there are risks to an individual injection, and then there are complications and things that can come from getting too many injections. So the risks of one injection are skin infection because you're putting a needle through the skin, and potentially nerve injury if the needle were to hit a nerve, or actually some of the steroid can be taken in by a blood vessel and cause a nerve injury. That's very, very unlikely to happen. We have safety steps involved to prevent those things from happening. The real concern with epidural injections is when they're done too often, and there's too many of them done. It can cause some local weakening of some of the muscles, the bones, osteopenia or osteoporosis people may be familiar with. You can cause that by injecting too much cortisone. You can also cause some inflammation of the tissue that surrounds the nerves, which become painful. So you really want to be more mindful of the number of epidurals rather than the risks of one or two epidurals, which are very, very minimal.
And what do you use do you have something like an ultrasound machine or something that guides the needle into where you need to go?
So it's an X-ray machine is used for epidural injection. So it's a live X-ray machine. We take a picture every time we advance the needle a slight bit. We take a picture to make sure it's in the right location. And then before we inject any medication, we inject what's called contrast and take another picture. The contrast will show up on the X-ray and will outline where the medication is going to go. So we're able to confirm the exact location of the needle, make sure we're getting the right pattern that we're looking for on the X-ray machine before we inject any medication.
And are these done in your office?
Most of the time they're done in surgical centers. This X-ray machine is a large piece of equipment. If patients want some sedation, you need an anesthesiologist there, so that's done at a surgical center.
So patients can do it without anesthesia?
You can do it just with a local anesthetic that will be injected.
And there's not a big pain risk?
There's very minimal. The only time I advocate a patient get some sedation is if they're afraid of needles or think they might move during the injection. And the sedation you get is very light. Most patients are still somewhat awake. They're just not really paying attention to what's going on. You're definitely still breathing on your own. This is not intubation, not general anesthesia. It's just light sedation.
Okay, we got a fun one for you now. This one's called Stat Chat. Stat meaning right now, and chat is a series of fun questions. You have 1 minute and 30 seconds to answer as many as you can. Are you ready?
Let's hope so.
All right, Matt, start the clock. Here we go. Favorite sport?
To watch is basketball, to play is golf.
Your favorite golfer?
Tiger Woods, despite his struggles.
Your favorite basketball player?
It's John Starks from way back when.
Yeah. Favorite major in golf?
No, the Masters.
You must go see one concert, Kid Rock or Elton John?
I would see both, but Elton John.
Elton John's actually playing right now, too.
Oh, really?
Yep. Favorite movie of all time?
That's a good one. I'd go with The Matrix.
Favorite actor?
Robert De Niro.
Coffee, leaded or unleaded?
Neither.
Do you like tea?
Don't drink much coffee. Yeah, tea's good.
Green?
Yeah, I'll go green.
Last fast food you ate?
How about pizza? Does that count?
No, pizza does not count.
We're going back at least 10 years. A Wendy's spicy chicken sandwich.
Did you get fries with that?
I'm sure I did.
Did you supersize it?
That I don't remember.
Salty or sweet?
Sweet.
You're trapped in a supermarket. What do you eat first?
If I have access to boiling water, I'm going to throw some pasta in there. If not, I'll go steal some chocolate off the candy aisle.
If you weren't a doctor, you would be?
I'd be an engineer.
If you could talk to anyone, dead or alive, who would it be?
It's a sappy answer, but my dad.
No, it's not a sappy answer, man. That's a really good answer. So this last segment is called Before You Go. And what that is give a really good tip to a patient that's coming to see you.
Sure. Don't be afraid. I mean, that's the one thing I hear more than anything with my new patients is that they were afraid to come see a pain management doctor. And usually that fear is based on how the interaction is going to go between the patient and the physician. And patients are worried that pain management doctors are going to force them to take narcotic medications or make them do 20 injections despite some of them not working. And that's really not what most pain management doctors do. That's not how we practice. It's definitely not how we practice in our practice. Our goals should be aligned with the patient's goals. And we listen to the patient, we discuss their treatment options, and we give patients the upsides to all of them and the downsides, and then we make a decision together about how we're going to proceed. It's not an authoritarian relationship where I'm telling you what to do. We're working together collaboratively, and we're coming up with a plan that's going to accomplish your goals. And as long as we agree on the plan, great. And it's a team approach. I don't tell you what to do. We work together. I give you my opinion. I give you my expertise, and then we make a decision based on that information.
And that would be collaborative instead of you just telling them what to do.
Of course, right. Yeah, we're working together. It's the way medicine is moving in general, but pain is sort of its own specialty. But medicine is working towards a patient-physician relationship that's more of a team. 20 years ago, 30 years ago, your doctor would tell you you're going to do this, and there's really no other options. Now, even with high blood pressure and diabetes, it's sort of a team approach. But in pain management, everyone's goal is different. Some people want to play sports again. Others just want to pick up their grandson. So we have to take that into account and figure out what the patient's goals are and work together collaboratively to achieve them.
That's good. Hey, thank you so much for being on the show.
It's a pleasure.
All right.